a lot of people were asking about hormone replacement therapy and breast cancer risk. And I don't know if you'd like to comment on that, but there's a lot of, I mean, I think some of that comes from the Women's Health Initiative, which we don't necessarily have to go into now, but, the population that they selected, the mortality risk of, they were smokers, they were overweight, they were like 10 years past menopause. And what I think still persists is when we are taking hormone therapy, it's going to increase potentially, and there may be a risk here that it increase, these hormone receptor or these hormone based cancers in breasts.
Yeah.
I don't know if you wanted to talk or expand on that a little bit.
Yeah, no, I think that actually there's a lot of overlap between breast cancers and ovarian cancers. And I spent my thesis, my PhD thesis work was surrounding ovarian cancer. And so there is a lot of overlap there regarding how specific hormones like estrogen can be associated to making cancers of the breast and the ovary worse. And a lot of that relies on the breast tissue because they're very important. Specifically, estrogen is very important in regulating the metabolism and basically cell biology of how breast and ovarian tissue form and how they maintain themselves over time as people get older, especially in women. Obviously, estrogen is also important for males, but, obviously more important in females from a variety of different biological perspectives or physiological perspectives. But just to bring people back onto the biology of how estrogen can worsen cancers over time, if people have a genetic predisposition like a BRCA mutation, and maybe they're not paying attention to their diet, they're eating a lot of, hyperpalatable foods, usually ultra-processed foods, it can kind of worsen the metabolism associated with estrogen production because estrogen is initially produced from cholesterol. And so if we consume exogenous cholesterol in excess, via, obviously caloric intake, it can worsen some of the characteristics of disease. And so if people are more conscientious of their diet or even things like exercise and sleep, they can reduce the risks even if they have something like a BRCA mutation or a variety of other mutations that can occur even in breast and ovarian cancers. The same is true for P53. I mentioned that already. It's pretty common in not only breast cancer, but I think like 50% of all cancers, there will be some form of P53 mutation. And those mutations do vary. They don't all do the same thing. Like there's, going back to P53, there's like gain of function. So you can mutate the function of the protein to gain something that it didn't have before. There's also loss of function mutations. So where you completely reduce the ability of P53 to regulate genetic repair processes that it normally does. So just because something is mutated doesn't mean that the mutation is the same across people too, which further complicates things. So yeah, that just kind of brings some of the biology back to breast cancer and ovarian cancer. And one thing I typically like to teach, sorry to continue rambling. One thing I typically like to teach is the two-hit hypothesis by Alfred Knudsen. So he essentially, and you can look this up, it's called the two-hit hypothesis. And this kind of simplifies why if we have a genetic mutation of a specific gene, it requires more than that event to induce cancer formation. So if I have a BRCA gene mutation or some other gene mutation that's prevalent through a variety of different cancers, that mutation alone isn't sufficient to induce tumor formation. It might be a start or like the start of the dominoes falling, the domino effect, so to speak. But there needs to be another either genetic event or environmental event that is alongside that event to induce cancer formation. So that's why I try and focus.
Necessary, but not sufficient.
Yeah, that's why I try and focus on the behavioral things that people can do to reduce risks. Because if you have a genetic mutation, you can't ethically change that. You can't genetically engineer that out of people without affecting the evolution of the human race, which is, an ethical consideration and artificial selection and whatnot. But yeah, that's where it becomes a bit problematic.
Yeah, and maybe you can speak to this with ovarian cancer as well. Mm-hmm. One of the arguments, specifically with HRT and its risk in upregulating or chunking up, let's say, risk for breast cancer, or the argument against it is that if estrogen was the big problem, that we should see theoretically more breast cancer in younger women where the levels of estradiol or the levels of estrogen are higher, mm-hmm. because typically what happens as we age is we have this wane, and certainly through perimenopause and then the menopausal transition, mm-hmm. we see estrogen levels plummet in perimenopause, but in menopause it's like down to 1% of those previous numbers, right? So if
Sure.
you are a fertile cycling woman, maybe somewhere between you're going to average somewhere between 100 to 250 picograms per mil, over the course of, the month. It's going to change. But then when we're in menopause, it's like 1% of that. So I think that there's been people who've pushed back on the estrogen or the HRT specifically. I think it's like the hormone replacement driving up breast cancer risk. Do we know is that a known when we are thinking about HRT, because this is a big, global conversation right now, is sort of bringing back HRT and sort of looking at the WHI as this, statistically flawed. The way that they cut and slice the data, the way that they select the participants, et cetera, was subpar. Are there known risks with HRT specifically, whether it's the estrogen and progesterone if you still have a uterus, or the estrogen alone if you don't have a uterus? And are we aware of any risks with HRT upregulating breast cancer risk?
Yeah, so I mean, it's been known for quite some time that hormone replacement therapy is associated with increased breast cancer and ovarian cancer risks, because the hormones themselves can, in some cases, be causative to specific cancers. It depends on, again, the genetic differences between people, but the way that these hormones work is to enable, again, this is probably an oversimplification, but the way that these hormones work is to enable growth processes that maintain normal cell biology. But if there's something that genetically someone has, like the BRCA mutations or maybe dysregulation of estrogen receptor signaling, it can increase their likelihoods of the things associated with estrogen receptor signaling and increase their likelihoods for specific cancers of the breast or ovary. And even then, there are subtypes within breast and ovarian cancer that HRT is more associated with. But yeah, I mean...
and is that just initially when you're starting to take the HRT? Is there... because I know that there's an increase, like we see an increased risk in cardiovascular disease. I think it's the first year, maybe two, of initiating HR. Is it in that sort of first little acute delta of starting the therapeutic, and then if you've been on it for 5 or 10 or 15 years, let's say, that it sort of wanes, it comes down?
So typically with these things, it's a dose dependent sort of thing. So the longer period of time somebody is spending on hormone replacement therapy, usually the greater their risks are for developing these sorts of things. But from a quality of life perspective, sometimes the pros outweigh the cons. So like in this case, the con would be increased cancer risks, but the pros would be like this person will have a greater quality of life if we give them this thing. And just one of those cons is greater cancer risk. So they try and give suggestions about, what people can do to reduce risks while achieving the quality of life that they can get from hormone replacement therapy. Because some people, realistically need these, like people that have PCOS. Frequently benefit from hormone replacement therapies. And if they don't have those, the quality of life is dramatically goes down. So yeah, they might have increased cancer risks if they're taking these things over time, but there's a variety of other things that they can do, not even through hormone replacement therapy, but through lifestyle interventions. And they're relatively basic that most people know about alongside those things to have a better lifestyle.
Sleep like a boss and lift like a beast.
Absolutely. That's the premise of my whole life, and I'm sure it is yours as well. Do your best, right?
You do your best. Absolutely. Okay. So let me just ask a clarifying question. So when you were saying the known risks for HRT, it's sort of dose dependent. So the longer that you're on it. So do we also see, so I mean, I think someone with a BRCA gene mutation probably is aware of that, or maybe, if they've done the genetic testing or what have you. You mentioned also disrupted ER signaling as well. Is there a way for you to understand whether or not there's some estrogen receptor dysregulation through genetic testing or any other means or mechanism?
Yeah, so oftentimes if somebody is diagnosed with breast cancer or even ovarian cancer, they'll often look at the level of protein expression and mRNA expression of, progesterone receptor, Herceptin, because sometimes people possess mutations in HER2 genes. They'll look at epidermal growth factors, all these growth pathways. They'll look at estrogen receptor. Estrogen receptor itself is a nuclear receptor. So it's on the surface of the nucleus. So they'll look at the expression of those things, and it can sometimes be indicative of the responsiveness of that specific cancer type to estrogen. Of course, there's a variety of different molecular characteristics that need to be determined, but it can be indicative based on just overall abundance of estrogen receptor signals that they can detect. Does that make sense?
Yeah, that totally makes sense. Okay, so that's actually great because that was my next question. Is like, okay, how do we know if you or anyone listening, how do you know if you have disrupted ER signaling?
Yeah.
And but there's ways that we can qualify that and quantify that, it seems like.
Yeah, in the clinic, typically, if someone is diagnosed with breast cancer or ovarian cancer, we can go in and perform some form of a biopsy. We can cut that tissue in a variety of different ways, do a variety of different experiments, whether it's histology, we're cutting thin sections and we're staining for specific proteins. We'll look for Herceptin, we'll look for progesterone receptor. And so one commonality between like breast cancer and ovarian cancer, you'll see, HER2 negative, HER2 positive, PR positive. And this is what's commonly, if you miss all those HER2 receptors, estrogen receptor, progesterone receptor, this is what's called triple negative breast cancer. And that's typically associated with later stage breast cancer or progression. And so the outcomes associated with that, because they've downregulated those things, they've adopted new mechanisms of promoting cell survival that we need to figure out what those are so we can, instead of giving like the newer therapies that target the HER2 receptor, we can't give those if they're missing the HER2 receptor. So we have to come up with other ways to better treat those people.